Hi, I'm Jens Chapman, and welcome to the Seattle Science Foundation. We thank you for your interest over the past years in our regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves on offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass. So coming 2025, please keep tuning in. Free content, high quality, always available, but please use the all-access pass if you need to claim CME credits. Thank you so much.
And we're live in 5,
4, 3, 2,
1.
Good morning, everybody. My name is Jens Chapman. Happy April 2nd, 2025. And greetings to you all. Thank you for joining us today on this non-CME presentation. Nonetheless, I hope you'll join us for our Gold Pass. As the ad said, today is a very special day. We have 2 stars in the field. The near and dear friends of ours, Dr. David Poley and Dr. Jay Turner, talked to us about spinopelvic fixation. And this is a very surgical topic, but it's a very great topic for the D part of STED Talks, Spine Technology, Education and Discovery, Debate, Discourse. This is definitely one of those subject areas that requires, for all of those of us who do spine surgery or think about the spine, a greater in-depth consideration. We want to express our gratitude towards SciBone. SciBone has been one of the pioneers in this field, and we have 2 pioneering surgeons as experts today. So we thank all those involved in the planning and execution of this. Dr. Polly, I want to recognize your tie. It's a particularly beautiful tie. And Dr. Turner, we have to have you here more often to get you the tchotchkes that come with coming here so often. But thank you both for being here. As always, we have some cases, and we want to be mindful of running the cases rapidly and rapid fire so we get to our main featured speakers. So Dr. Kramer, your surgical colleague from Wisconsin, has our first case right out off the press.
Okay, we'll start off this case. This is a 6-year-old woman. She's presenting with quite bad and worsening low back pain and bilateral foot drop. She's got.
You're not seeing your slides. Oh, okay, now we're seeing your slides. Great. Perfect.
Sorry about that. She's got a history of metastatic breast cancer. She's been dealing with this for over 20 years, and she's had a variety of operations in the past. It sounds like her first operation is almost 10 years ago. It's just a laminectomy, and this is followed by a fusion a few years after that. She actually had some tumor involvement in the lumbar spine as well at L3-4. It sounds like it was epidural. I don't unfortunately have that imaging available for review. She had a laminectomy and tumor resection, and this was about 4 years ago. And then after that, it sounds like she broke down a little bit, so they extended her fusion up to L2, and then has been dealing with kind of persistent low back pain since that time, and ended up having a spinal cord stimulator implant placed as well. In regard to her current status, she actually has a very favorable tumor profile, and she's on some chemotherapy, which has been quite successful for her. Also of note, within her past medical history, given pretty bad osteoporosis, she was actually on bisphosphonates for almost 10 plus years and dealt with some complications from that as well. Here's her exam. You can see nearly complete foot drop bilaterally, and then now she's dealing with some more proximal weakness, right side worse than left. Here's her x-rays. or radiographs. You can see that she's got obvious lumbar deformity. She's got multiple broken rods, attempted fusion from L2 to 5. Here is, and actually just to also note, these are the Scully films. And to note that she's got pretty bad coronal imbalance. She shifted to the right almost 5 centimeters. Her sagittal balance actually is not too bad, despite her awful looking lumbar deformity. She's only positive about 2.5 centimeters. So here's the CT, the coronal CT. You can see at L3-4, this is kind of the area of major concern. You can see there was an interbody fusion attempted. There's listhesis there, collapse, and there's both coronal and sagittal deformity at that level. And the sagittal here well demonstrates that. And she did have an MRI as well. You can see a couple of selected slices with quite severe stenosis at L1-2, just above the fusion, and also at L3-4. And also of note, this is not too far away from where the spinal cord stimulator was placed, and there's a large pocket of some fluid in the paraspinous region as well.
All right, so a lot of, yeah, okay, go for it, yeah.
Just briefly as well here, thoracic imaging was performed, no obvious issues there. Her bisphosphonate therapy may potentially alter this, but she did have a fairly interestingly high Heinz-field unit measurement in her, this is at L1. And just last, before we kind of summarize everything here, she did have some involvement of the right iliac wing of her cancer, which also showed up hot on the PET scan. So in summary, 6-year-old woman, she's got metastatic breast cancer, prior 2 to 5 fusion. She's got this acquired kyphoscoliosis, quite bad lumbar deformity. She's quite rapidly deteriorating. Within the last few months, she's no longer able to ambulate all that well independently, and quite severe bilateral foot drop.
So, doctors, there's so much to talk about that we fortunately don't need any other lectures. We can basically cancel the rest of the morning. In fact, I think it's only today to discuss this case. Corey,
Can we go back to the plane films, the full spine films?
So 3 things I want to concentrate on. When should we go to the pelvis in a postmenopausal woman? Number 1. Number 2, the role of stimulators and possible derangement. And number 3, how to fix this problem. Now, how do we get out of here? So, Dave, do you want to take the first lead? What are you looking at in the scoliosis films?
Yeah, so several things. Number 1, the coronal imbalance. Number 2, the sagittal imbalance, and that she's maintained reasonable sagittal balance by hyperextending her thoracic spine. And so she's using her compensation mechanisms, interestingly, not significantly retroverting her pelvis, but that may be due to weakness. And if she's got L5 weakness, sometimes the piriformis muscles and some other gluteal muscles are a bit weak as well. And so when I look at this is coronal and sagittal imbalance, pseudoarthrosis, mechanical instability, and neurologic compromise. Other than that, pretty straightforward day. So my goal is to get her realigned, stabilized, decompressed, and fixed well enough. You know, the great news about the treatment of breast cancer is the survivability's gotten much better. And for us as spine surgeons, that means we've got to do a better job of fixing them, because they're going to outlive our fix if we don't get them to heal. And so that's my starting thinking point about where I'm going. The wild card about the right-sided metastatic disease, I think, given that she's got widely metastatic disease, that you just sort of say, okay, it is what it is, and I'm going to span that, and I'm going to fix to that. So I'm thinking typically I do posterior, but an ALIF at 5-1 would really help. what your ability to do at the collapsed segment with the interbody device in there. A supine CT scout sometimes helps, shows you a vacuum sign, says it'll move. Certainly you can do a corpectomy from behind. I don't think you're going to have to do that. I'm going to do a lot of intradiscal work to try to make things robust. And I'm using multiple rods to the pelvis for her. So even if she doesn't heal, that she's below fatigue threshold. So that's my initial thinking process about what I'm seeing with her.
Dr. Turner, in adult postmenopausal females, should we go to the pelvis routinely, and how much effort in the primary surgery should we exert on leveling the L5 vertebra out so that we don't have this catawampus kind of a takeoff of the lumbar spine from the pelvis?
Yeah, good question. So yeah, I think for someone like her, you can, certainly some major risk factors with the osteoporosis. And if you go back to her, we had her MRI there. You can see she's also sarcopenic. She's got itty bitty psoas, and so she's got kind of that double whammy: poor bone, poor muscle tone, which sets her up for a high risk for failure, regardless of what we do. And then you add most likely a radiation bed onto an area that you're trying to fuse, which is not going to be favorable to fusion. So we've got a lot of things working against us. And so I look at this and I'm thinking, if we're, you've got this neurologic decline with a presumably favorable oncologic diagnosis, I think you got to go big, and we're trying to preserve function, hopefully restore some function. And so the neurologic piece is a key part of this. Looking on the surface, it seems like a fixed deformity, which means a 3-column osteotomy. But if you kind of look down into the CAT scan, you see all the pseudoarthroses and broken rods. And so, to Dr. Polly's point, there may be some disc spaces we can take advantage of to get that the fractional curve neutralized. Because I agree, if you don't take care of the base there, she's going to be pointing further over to the other side if you don't take care of the base. So yeah, so I for something like this, there's no question about going to the pelvis. The tumor in the pelvis is an unfortunate bystander that I think we're just going to have to accept. It's going to be part of her systemic treatment. I'm sure some targeted treatment as well with radiation there. But yeah, absolutely, it's 100%. This is going to require some pelvic fixation to build a strong base, given all those risk factors and given what's going to be required. And so, getting her straight in both planes is we're getting her straight in the coronal plane, and getting her sagittal profile realigned is going to be critical for kind of a good long-term outcome for her.
So great answer, Dr. Pauly. 4 rods nowadays and 4 pelvic screws, or are there better pelvic fixation devices out there now?
Yeah, so I'm going for 4 points of pelvic fixation. I happen to like the screw fusion devices, but 4 points of pelvic fixation and 4 rods is the best data to date. And then again, the question of durability, and if she's going to cyclically load these a lot and not heal her bone, potentially having an ingrowth screw may be advantageous to obviate screw loosening of the pelvic fixation.
All right, Dr. Kramer, in the interest of time, let's take us forward. I know we could talk forever about this. What was done? What was the thinking behind this?
Yeah, so this is what we did. Hardware removal, we spanned T10 to the pelvis, bilateral S2AI screws. We ended up doing a intradiscal osteotomy at L3-4 to kind of regain that correction. And you can see there is the suggestion of one old screw at that level, which was not removed. It was left in place. You can see the overall coronal correction and sagittal correction were quite good. She actually did very well after this operation. She was actually discharged home.
And quickly, I'll ask the surgeon, Rod, this looks beautiful, but and I'm surprised what you got there. Why no 4 rods? Why no 4 pelvic screws?
I mean, honestly, that's a great question. And I think you could easily put 4 rods and put 4 pelvic screws. I think you guys talked about this, but to actually operate on this patient was really ethically, and I mean, it took a long time, and then she rapidly deteriorated. And so that's why we ended up doing the surgery, because she's been, I think, 20 years, she's been battling breast cancer. I think you guys saw she's got that big deposit in her pelvis. So it was not an easy decision. And I think, going back on it, and she had previous radiation, I think you can easily put in 4 pelvic screws.
So take us forward, Mark. So the saga's not ending, and again, we're going to focus on the pelvis today, but
Yeah, so I guess long story short, she does well initially, and it's about 6 weeks post-op. She had already gotten some of her Scully films done at this point, and she reported a fall at home. And at that time, she called the clinic and said, she's having more difficulty ambulating, and she feels like although made some initial progress, now she's declining. So this is the immediate post-operative CT on the left, sagittal, and then you can see at 6 weeks, a repeat CT was performed. And I have a closer view. You can see that she basically has a sagittal split of that, or coronal split of that T10 vertebral body.
So both of you have published in this domain of proximal junctional failures. Any wisdoms, anything to prevent that? The fall at home is so common. She has L5 weakness. So what are your thoughts on in a sarcopenic patient with a biphosphonate therapy, it's an antiresorptive therapy for a long period of time, something's going to give. How to prevent the rostral failure in 1 or 2 thoughts? Start with Dr. Pauly, go on with Dr. Turner.
Yeah, so one of the questions is screw angulation using an anatomic screw trajectory at the top may be helpful. And then at this kind of level, I have a low threshold to use a tether. And then we always get in the debate stopping at the lower thoracic versus going to the upper thoracic. Lower rate of failure if you go to upper thoracic, but bigger surgery. And then when they fail, it can be more catastrophic. And so that's, I think, the current state of the art. And I hate bisphosphonates because of this kind of reason. And I am really a fan of the anabolics, and the challenge is in cancer patients, can you use the anabolics?
Great summary. Dr. Turner, anything to add or differentiate?
Yeah, I mean, I think that where to stop at the top is always the question. I like this UAV. I think it's just part of the risks in somebody who's got bad bone and bad muscular envelope. My go-to has been I cement the top and I band essentially all these. I think it helps a bit. I don't know that it would have prevented this from happening, but I do like the kind of anatomic trajectory just to give a little bit of mechanical support on that pull out, and then augment the screws to kind of disperse some of that stress on the tip of the screw to reduce the chance of loosening and maybe protect against fracture. So but yeah. Unfortunately, with it, regardless of what strategy you use, this is one of those risks you can't. We're all vulnerable to.
We'll carry on. So lower thoracic spine, and here we move to the upper thoracic spine.
So sadly, yeah, this saga continues. So she does well after we extend her up to T4. We do a laminectomy at that level as well. Again, within, in this case, a week, now she starts declining again. Initial improvement for a few days and then decline. And we were a little befuddled. We got a bunch of additional imaging, ended up getting a CT myelogram, basically the entire neural axis. And you can see again, now she's collapsed at, we went up to T4, and now she's kind of kyphosed at 3-4. And it was actually just recently we extended her even higher. So, and performed a laminectomy at that level.
And welcome to the show.
So the fight to perform something unphysiologic for human beings, a fusion, escalates into this even greater and greater attempt at trying to turn the mobile spine to a rigid one. Any thoughts on rostral landing, T1? What tethers do you use? So maybe start with Dr. Turner because he brought up the tether again.
Yeah, I mean, I think trying to, you got the advantage of stopping at T4 is that gives you a few extra segments above before having to go into the cervical spine versus going up to T1 or T2 up front from the extension down from up from T10. Did she have a spinal cord injury as a result of this? Was she neurologically declining?
She developed myelopathy. She's probably pulled up on her arms pretty early post-op. So this is the eternal problem with our beds. The patients slide down, and the easy, convenient thing is to pull them up, their trunks up on their arms. That's what I suspect happened in her. But so the fight's continuing. Is T1 more protected? Dr. Pauly, is T1 a better level to stop at rosterly than T2 or 3, or should this just be going to C2?
There's no data on that, Jens, and it's sort of wherever you stop, you're at a risk. Even if you go to C2, you can fracture the dens. But what unfortunately, I have experience with these kinds of scenarios. And one of the things that's been helpful for us is to T-TIF the kyphotic level. And so we then don't have to go up as many levels, and biomechanically, that puts a little less stress on the posterior instrumentation, and I think is a little bit protective. And so generally what I see being done in the world is overcorrection above the kyphotic segment. And what we've tried to do is correct at the kyphotic segment. And so then, maybe just going up 2 levels instead of going way up into the cervical spine. And with the inner body support, that offloads the posterior instrumentation a little bit and may make it a little less likely to fail. It requires special cages that are small enough to fit in there, but we've done that a number of times, and I think it has saved some levels and maybe lessened subsequent adjacent segment failure. Maybe.
Dr. Turner, yeah.
Yeah, I mean, this is different from the first PJK. This is a ligamentous failure. So discal ligamentous failure. You can see the sublux there, and you can see the disc herniation. Were the screws at T4 still a good purchase? Or had they failed as well?
We actually used the robot for placement of all the screws, and so we angled these screws in and designed them to get as much purchase as we could. But sadly, like even on these revision cases, those top screws were all loose.
Yeah. So I guess the question here is if you did some banding or posterior tether up front, is that going to provide some extra ligamentous support for a ligamentous failure in the upper thoracic spine? Maybe that offers some protection. And when I do T4 UIV, I'll do essentially a figure 8 weave through T3 up to T2 to support the top 2 levels to create that transition from the rigid, metallic artificial spine into the more physiologic spine. And perhaps that provides some support, but the data is pretty weak out there right now from at least from a clinical standpoint.
So right. Jay, one lesson I had on tethers, initially I tried to tighten them as much as I could, like when we were doing sublaminar cables. And I think that that's probably wrong. I think if you tighten them too much, they're acting like you're fusing those segments. What you want is a mild tension, and I'm not quite sure I know how to define that, but I think that matters in tethering.
Sorry for rushes, but Dr. Kramer, thank you so much for a nice case presentation. And the lessons in this case are the more pelvic stability we have, the more the rostral motion segments are bound to fail, number 1. And number 2, our patients tend to lead longer and potentially more unhappy lives unless we play our cards right. To illustrate this case, we'll ask Dr. Colin Gold to present us the next case. He is originally from the University of Iowa, a neurosurgical colleague, and he had a case that he was involved with to demonstrate.
Thanks. So this patient is a mid-60s-year-old man who presents to the emergency department after being referred by his PCP for an imaging finding with years of progressive low back pain, no leg pain. He denies any bowel or bladder dysfunction. His past medical history is significant for diabetes, hypertension, neuropathy. He's a retired chef and lives alone. Here's his physical exam. So he has weakness in both legs, most significantly on the right, and pain limited with any kind of movements of the right hip. He is slightly hyperreflexic in the right patella. And otherwise notable for weight-bearing difficulty with the right leg and positive single leg raise test on the right more so than the left. Here is his imaging. So on the left here we have sagittal T2 MRI of the thoracic spine. So you can see central spinal canal stenosis most significant at T11, T12, and a little less so at T9, T10. Here's a lumbar sagittal MRI that shows spinal canal stenosis centrally and a little bit of coronal deformity from L3 to S1. And then On the right is a coronal CT demonstrating a lytic lesion in the right sacral ala that somewhat extends into the right S1 neural foramen.
So we have two problems. We have a patient who has significant gait problems, and we clinically think, correct me if I'm wrong with that recollection, Colin, that this is probably induced by that T11-12 disease process, but then in very careful serial exams and talking to the patient, having him functionally try to stress, he clearly has lumbosacral pain on the right side as maybe even the main lead concern. And he has a, as of yet, undiagnosed neoplastic disease process, but his walking capability has been significantly reduced. So what to do, how aggressive do we want to be? We don't know what the disease process is. He's pretty impaired at this point in time. He is basically just semi-bedridden. This is an extremely functional guy until now. Dr. Pauly, do you want to take a lead?
Yeah, so he represents the diagnostic dilemma of where is his pain coming from. And we didn't really focus in the SINS criteria about what constitutes pelvic instability. But to me, I think Mark Bilski has taught us all that if he hurts when he sits, if he hurts when he lays down, and if there's any mechanical component to it, he probably is mechanically unstable in his pelvis. And if he's mechanically unstable in his pelvis, you're going to need to stabilize it. The question then becomes origin of the lesion and prognosis, and then how much do you go after the other stuff? And so in our hands, this would be a biopsy with facilitated pathology to try to understand it, and then looking at a reconstructive decompressive effort and a long conversation with the patient about options of just fix the pelvis versus fix everything.
Jay, do we go down towards the pelvis also? Do we address this? Do we do it staged? Do we wait the week-long biopsy results game?
Yeah, I think I want to lead into kind of the acuity of the neurologic symptoms. That concerns me. Obviously, if it's an acute neurologic deterioration, the longer that gets left untreated, the less likely it is to recover. So, it sounds like he probably has mixed deficits from both spinal cord compression and compression of the caudal equina distally. He's got distal weakness as well, and he's hyperreflexic. So it sounds like both of those are contributing to his neurologic deterioration. So I want to lean into that. If this is something that's been going on for a while, I agree. I think trying to understand kind of his general health, what kind of tumor that is, and how that's going to be managed. If it's a more acute process, we may just want to decompress, make some space for nerves, and sort out kind of the bigger strategy. I want before doing anything reconstructive, hopefully try to get some standing X-rays if he can stand, at least some seated X-rays to get an understanding of his alignment.
Colin, what were your thoughts? You saw the patient serial. Also, you were very helpful. You were able to establish a good relationship and prospective assessment of his well-being. What was your thought?
Yeah, one additional piece of information I forgot to mention, he had an elevated PSA, so we had a little bit of an idea of what kind of tumor this was going to be. We talked about all these options with the patient and ultimately kind of let him decide where he wanted to go with this, of possibility of a few different surgeries, one different surgery addressing 3 different pathologies, or kind of one big surgery, kind of linking it all together with one pathology. And ultimately he said he wanted one surgery if possible, and did not want to be hospitalized and wait for the week-long results of a needle-guided biopsy just to have a surgery. So we ended up doing posterior T10 to L1 laminectomy, partial facetectomy, and T10 to L1 fusion. And then L3, L4, 4-5, and 5-1 decompression only with midline sparing hemilaminotomies. And then we did a right S1 to S4 sacral laminectomy and partial sacrectomy. We removed the mass and filled the space where the tumor was at S1 to S2 area with PMMA, and then did lumbopelvic fixation from L5 to modified iliac screws with bilateral iliac screws on the side of the tumor. Here's some post-operative imaging.
So it turned out to be prostate cancer. And again, the focus is here, we did 2 separate surgeries. We kind of did them almost at the same time. We left a fascial bridge standing between, a very arguable point whether that's worth it or not. But we did a midline sparing decompression at the lumbar spine. We just felt very strongly that both areas were a problem. And if you look at the pelvis, so we basically cored out the right ala and we put cement in there as a radiolucent kind of a dead space filler. It's not a bonding agent, to be very clear. And we put in dual pedicle screws on the more affected side. So we see a lot of these lumbopelvic tumor manifestations. Thoughts on how to reconstruct that and a metastatic disease, likely prostate, say at the time, histologically not proven yet. How can we reconstruct the pelvis in a relatively not acute but more urgent setting? How much material should we put in? What's the ideal reconstruction? Maybe Dr. Turner start first and then Dr. Pauly second.
Yeah, I mean, I think, for metastatic disease, you want to have enough support. You're not going, this is not an en bloc sacrectomy for a primary spine tumor. You're essentially decompressing and stabilizing. I like that you had that cross link there connecting the 2 sides. You want to, kind of reestablish that posterior ring in some capacity. I'll often use kind of transverse rods to connect 2 of the bolts together and then connect that into vertical oriented rods. I mean, I think this is a very, good solution. I think it's very reasonable. Question of decompressing the levels above L5 but not fusing. It's the question in these settings is always how little or how much to do. I think you took care of all the most urgent issues there. I think that's a very reasonable public strategy there.
I'll pass the microphone off because we're having a change of speakers now. Dr. Gold, how did the patient do from your perspective? We don't have long-term follow-up yet.
So the patient is doing well oncologically. He's having persistent pain. So I know he's involved with palliative care for ongoing pain management. No leg pain, but ambulatory. So overall better functionally than he was when we started.
And we have a more recent case with Dr. Kevin Hogshead from the Dallas-Fort Worth area. He was going to sign a contract and now he's unsigned. So anybody around the country who needs a great young surgeon with a bright mind who works super hard, he's available. Talk to me. I'm his agent.
Thank you, Dr. Chapman. So this is a case of a 53-year-old female with worsening left hip and pelvic pain. She presented with these pelvic x-rays that you can see on the left. She described it as a constant ache that was now debilitating for her. She felt like it was now worse than before her left SI joint fusion that she had over a year ago, and it's now requiring increasing opioid doses for that pain. She had poorly exhausted physical therapy, the SI joint injections. She said she didn't get much relief from originally in activity modifications prior to this left SI joint fusion. You can see past medical history significant for hypothyroidism as well as osteopenia. And her social history, no tobacco use, risk factors for non-union. She does take THC and CBD for pain on a regular basis. She works as an office administrator and is a very active person. She skis for fun. But has been fairly limited in her quality of life from these symptoms. No bowel or bladder symptoms, and she had some preferred left leg pain and numbness, also an antalgic gait. She had some classic positive findings for SI joint pain, tenderness there, Fabers that referred into the back SI joint area. And then she's a thinner lady, BMI of 20. She did have on her most rostral SI bolt there, some prominence and tenderness to palpation. I think her motor exam was more limited by pain than really neurologic symptoms there. This is a CT scan that she came in with, axial as well as coronal.
So that's a little hard for us to see on the screen. Did you all think that there was haloing on the sacral side or not?
Yes. And there's a
Okay.
TC9 and bone scan.
Mhm.
Are you
Yeah.
going to show it next?
Yes.
We can visualize what's going on with the osteoblasts in a second.
So there's some radiolucency, some surrounding sclerosis, no bridging bone in SI joint, and concerning for pseudoarthrosis.
Yeah, usually for me, a Ferguson view or a true AP of the sacrum is even better than the CT scan to try to pick up the halo formation. And I think there's two components. One is to look for the halo, and the other is that oftentimes there can be a sclerotic rind that forms around the halo. And if I see that, that's pretty compelling. And so I think that that is an important consideration. And the mock effect from the CT scan, sometimes it's just hard to interpret. And that we found that if you use the temporal bone windows, that seems to help decrease the mock effect a little bit.
Now, if you look at the top left image, Dr. Hawks had put that up. She had a SPECT scan. There's also a colored version of that. What really surprised us, something is going on very badly.
Yeah.
She has no systemic disease, but this is like, how far out is this, Cameron, on the top left, that bone scan? 8 months out?
Yeah, it's about 8 months out.
So
Yeah.
no infection, no inflammatory signs. This is a hitherto normal person with normal bone density. She's an athlete, and she's in absolute misery now. And she's broken her anteropelvic ring now. No trauma on repeat, careful asking, and a hot bone scan. This is, yeah, go ahead, Cameron.
Yeah, these are actually some images we were able to obtain and get access that you could see from her before her surgery, and remarkably, just from these images, not seeing pretty benign appearing SI joints bilaterally in MRI. And so, it's a question of, indication or pain generator was really her pain generator originally, but now she is having worsening pain there with hardware and a pseudoarthrosis. MRI here was obtained as well. She's no corresponding neurologic disease that could refer to her symptoms that she's having now.
So again, this has gone out of control there. She's gone on serious doses of opiates. She has a hyperactive TC99 bone scan in that area. She has, by CTs at least, radiographic loosening. I think there's some in and outlet views, but I'm not sure where they are right now. But we studied her pelvis, given her opiate burden of a previously opiate naive patient. I detoxed her first. I put her into rehab. I did not want to touch her. I gave her an electromagnetic belt. But at this point in time, Dr. Turner, any technical concerns about how they were placed, aside from the fact that this patient on a first visit with a surgeon got one injection done apparently, and then was indicated for this fixation, which is discussion worthy also?
Yeah, I mean, Dr. Polly has an awesome slide that shows the differential diagnosis of buttock pain in this location, which is vast. And so not all PSIS pain is SI joint pain, to your point, Jens. And so I think getting this diagnosis right up front is absolutely critical, and some of that physical exam. The confirmatory injections is beneficial, and then ruling out all the other potential masqueraders in that area. The lumbar spine is one. There's local nerve. There's a long list of other possibilities that could present with very similar presentation as SI joint pain. I don't know how it is in Seattle, but in Phoenix, SI joint fusions are rampant. Anybody with pain anywhere near that region is getting an SI fusion from somebody, especially the pain doctors in our area. So it's a problem in our market as well. And now you've got a new problem. It's hard to know without seeing the patient beforehand whether it's indicated or not. But we see a lot of unindicated SI fusions in our market for sure. So that's I think my biggest concern of seeing this was it indicated up front to begin with, was it even SI joint issue? It clearly is now. She has loose implants for SI joint, which I'm sure is contributing to her pain, and she is going to require some sort of revision here.
Dr. Polly, technique, indication, both?
So the first thing for me is that the diagnosis of SI joint pain is a physical exam diagnosis, not an imaging diagnosis. So I want to do the provocative maneuvers. So pelvic gapping, thigh thrust, Faber, Gainslands, pelvic compression, and sacral thrust. If 3 or more of those are positive, you have an 85% positive predictive value that the injection will be positive. Next thing is that I am very insistent on seeing the imaging of the injection. If I don't see the picture of the injection, in my mind, the injection hasn't been done. And if I have any questions about the injection, I send them for a CT guided injection where I know with 100% certainty the needle is actually in the joint and we're blocking the joint, not the neighborhood. And the next thing is, what was the volume of injectate? If it's over 2 cc's, you've flooded the area and you have no idea what you blocked. So that's sort of my starting point about the diagnosis. The diagnosis is physical exam confirmed with an appropriate diagnostic injection. Next step is non-operative treatment. And then if their ODI is in the 50 range, they failed non-operative treatment, all the other things are positive, then you have about an 85% probability that you're going to make them better with an SI fusion. If you have an 85% probability you're going to make them better, you have a 15% probability you're not going to make them better. Okay. And so let's say give the benefit of the doubt that this was appropriate, and I can't comment if it was or not. Technically, it looks reasonably done. It's a dysmorphic sacrum. So in a dysmorphic sacrum, I navigate these and I'll put the cephalad implant a little more angled cephalad to correspond with that dysmorphic sacrum. But when these fail, 99.9% of the time they fail because the sacral bone density is less good than the iliac bone density and they loosen there. So my diagnostic algorithm for this, number one, rule out piriformis syndrome, which the origin is just below the SI joint, very common, often overlap. Rule out cluneal nerve above, quadratus lumborum, facet. You've done a nice job of looking at the lumbar spine. All those things have to be ruled out. Now, my physical exam, same provocative maneuvers. And for this, I want a CT-guided diagnostic injection. If that gives her the transient relief, then the revision strategy is actually not too bad. What you do is you deliver K-wires into the implant. I use a lateral interbody fusion. I prefer the Medtronic one because it's got a screw that you can screw down to the ilium, has less muscle creep underneath it. And then there is a 3-sided chisel to remove, and there is a screw fusion device that is 13.5 millimeters in diameter that I can replace it with. So for me, a revision in a scenario like this takes only 20% longer than the primary.
All right, let's see what we did and get your criticism because we want to switch to our two lecturers.
So our plan was for a complete hardware removal with a robotic revision. Yes, hearing me correctly, robotic revision, SI joint fusion with a triangle construct for stabilization. And this is actually a intra-op spin after the bolts were removed. And you can appreciate the amount of bony deficit here after those bolts were removed in the,
How'd you do the removal?
in the sacrum. So she originally had about a 1.5-inch percutaneous incision on the lateral buttock that we extended. We were able to get down muscle sparing and create windows to visualize each bolt. There was a little bit of bone growth over that we osteotomed and chiseled off, and then we were able to use a distractor with a back slap to basically extract the bolts. We did have to chisel, do this, as you mentioned, the 3-sided chisel for most of the bolts because they were very difficult to remove.
Key comment here, you usually only have to chisel, typically the iliac depth is usually about 20 millimeters. And so you go 20, 25 just into the sacrum. And then there's something called a femoral stem extractor that is a really nice slap hammer that lets you get those out easier.
Mm-hmm. And so move forward here. This was our robotic planning here, is our triangle construct. And so you can see a S1 pedicle screw, a S1 body sacral iliac screw that we replaced, I believe is a size 12. And then a medial entry iliac bolt for our triangle construct. And then we did an open arthrodesis. And so confirming with navigation burr and chicken foot, we were able to curette and burr the entire SI joint and also replace, backfill it with BMP and bone graft.
Do you have the final CT?
Yep. These are other intraoperative photos. And there you can see a top right photo of us as well with 2 robots in the room.
Mm-hmm. And
this is our final CT.
We filled the screw holes with fibula strut graft also because, or the old grafts. So any criticism? This is a triangle fixation now with a larger implant with a compression feature, open bone graft. This turned into a much bigger surgery, but again, she had an anterior-pelvic ring fracture. So whatever was going on with her SI joint fixation previously did not just not work, but it actually escalated into anterior-pelvic ring fracture, which is now healed. And she now has a triangular fixation in there. Thoughts about the biomechanics of this versus the bolts put in before?
Well, I mean, it's different. This was originally described in the late 80s as a SI fusion technique of using an S1 pedicle screw and then an iliac wing screw. And I'm blocking on the gentleman's name from Michigan who did it. And then throwing in a iliosacral screw.
It was Mark Asher.
No, it's before. It was different from Mark. There was a guy in Michigan who was doing this in the 80s. But anyway, Mark was the one who advocated for an iliac. He was the first guy using iliac screws. And so I think that you've spanned it in a number of ways and you bone grafted it. And whether this is better or worse than alternative strategies, we don't have any data, but it addresses the pathology that you've encountered. And I think one of the key things is on the removal of the implants is how much of a void do you create. The less void you create, the easier the reconstruction, the greater the void, whether it's pre-existent or whether you create it in removal, requires a more aggressive approach for reconstruction. And a key point on the iliosacral screw is that you've gotten medial to the foramen and that you're in the S1 body, which is where the best bone is, versus a standard SI fusion, which is just barely approaching the body. And so the quality of the bone purchase is significantly improved when you do that.
We'll start with Dr. Turner. So SI joint fixation, one fundamental problem I have is with the bolts, regardless of what manufacturers were thinking of, is the lack of compression. Being an old trauma and spine fellowship trained surgeon, I've always liked the compression effect on SI screws, and I just don't see it with these bolts, even if you use 3. How important is it to compress across the SI joint?
Yeah, and I think it's probably important to compress across it and load it. I think the biggest challenge is from the posterior approach when you're going from the soft sacrum into the hard ilium. So from the posterior approaches, which is becoming more common, you can certainly with non-screwed devices, as you're malleting into that harder bone, that can be more problematic. Going from the lateral approach, going from the hard pelvic bone into the sacrum, I think that's less of a problem. And really the concept for the kind of 3D printed lateral SI fusion is more of a kind of a spot welding technique in order to get fusion across into each implant, as opposed to a robust arthrodesis cleaning out the entire joint. So it's a bit of a different philosophy.
So talk about SI joint fusion, Dr. Pauly. So Dr. Turner brought up the spot welding. This has been, again, the other significant criticism on these bolt kind of fixations, where there's a hope in on growth into the material surface of the device rather than crossing bone across the SI joint. How important is it to cross the bone over, or is this kind of spot welding sufficient if you have enough implants in there?
Yeah, so Jens, this is a great point, and I have a strongly divergent opinion compared to you on this one. So when we have trauma disruption, you're bone grafting and you're applying compression. And an interesting question becomes, how long does the compression actually have an effect? And it's probably hours or at most a few days. And so Mark Swinkowski and I have done a number of open anterior SI fusions. And I think when you do that and decorticate and graft, that your intent is to apply compression in order to enhance bony spanning, and I know Woody Cross is a fan of that as well. However, the data on the fusion devices, whether they be triangles or the torque screws, is that you get bone ingrowth on both sides, and human retrieval specimens have demonstrated robust bony ingrowth, and that there has never been a broken triangle or a broken torque screw that has demonstrated that there's been failure. Just like when we get fixation, robust fixation in a femoral stem for an uncemented total hip arthroplasty, that doesn't fail at the point of fixation. And so Now we go back to clinical success rate, and in an appropriate selected patients, 85% of the time using this approach, we have a clinical success. So again, I think it's a batting average question, and I have disagreement about the need for compression. I think we have the need for stabilization and elimination of motion that generates the pain, and that if we successfully achieve that with a biologic solution of the bony ingrowth, then the implants are robust and don't fail. But if we don't get bony ingrowth, whether you put compression or not, you get failure.
Thank you for your comments, both of you, and thank you to our fellows. Apologies to Dr. Nick Minisali, had another very interesting case of a Chapman lumbopelvic fixation failure that we wanted to tee off your lectures with, but we solved that with a compression fixation with 2 SI screws, actually. So this was a nice conduit, but time is of the essence, and we have the great privilege of having 2 fantastic speakers today. Starting on the right side with Dr. Jay Turner from the world-famous Barrow Neurological Institute in Phoenix, Arizona. He's a neurosurgical colleague and has done extensive fellowship training in San Diego, California, and Zurich, Switzerland. And he's a nationally renowned speaker in the deformity world and a frequently and gladly seen guest here. And sorry, Jay, no disrespect, but the better dressed guy today, Dr. David Pauly, that tie just makes you an immediate winner, is a professor and chief of spine surgery in the Department of Orthopedic Surgery, holder of the James Ogilvie Chair and the Catherine Mills and Davis Landgrave Chair in Biomechanical Engineering. And it saddens me greatly to announce that he is retired. He's in great shape and he is ready to enjoy life. And I very much hope to be able to make it to his retirement celebrations end of this month, but he's a professor emeritus with us now. And it's so cool to have 2 great minds together about spinopelvic fixation failures. And I hope these cases served as a fruitful intro to this topic. I don't know how you're going to divvy this up, whether you're going to speak parallel, overlapping, or how this is going to go.
We got it, Jens.
I'll just shut up. Thank you both for being here.
All right. Well, thank you, Jens, and it's always great to interact with the high-quality programs of Seattle Science Foundation, and you all have no shortage of challenging cases to set up the situation. So this is a non-CME talk, and so because it's a let's see, it's not letting me advance my slides. Oh, there we go. All right. So it's important that we identify instructions for use in this kind of a talk. So here's the evolution, and Jens can recognize all these implants. I'm sure he's done all of them, and that this is the course that we've tried to improve how we're doing, because we're not doing perfect on spinopelvic fixation. One of the key understandings when we're trying to fix the pelvis is understanding the regional bone mineral density within the sacrum itself, that the sacral ala has vacuous bone, and that it's only really in the body that we get reasonable quality bone for purchase with our implants or devices. Old data from the 80s told us that medially convergent S1 screws are better than laterally divergent. If you go straight ahead and you go bicortical, you put the L5 nerve root directly at risk. Ron Lehman, when he was with me at Walter Reed, did the study where we looked at if you go tricortical into the sacral promontory, you double the insertional torque going with the conventional compared to the parallel to the end plate of the sacrum. Iliac screw trajectories, as appropriately noted by Dr. Chapman. Mark Asher is the one who really taught us about this in the teardrop view, and that there are a couple of pathways through the teardrop, but this is key for where we've gone today. Probably the most important biomechanical study is the McCord-Cunningham study, which established the L5-S1 pivot point. If we extend anterior to the pivot point, we alter the biomechanical performance. Instead of inline pullout, we now experience cantilever loading across the sciatic notch, which is perhaps the best bone in the body. So our group studied this and looked at insertional torque, and what we found is that at about 80 millimeters, you hit what's called the second narrow point, and the insertional torque significantly increases, improves purchase, and bigger and longer turns out to be better than smaller and shorter. Can multiple iliac screws be done? I love this anatomic work out of the Seattle Science Foundation, looking at different trajectories, indicating that multiple pelvic fixation points can be obtained in the same ilium. and that there are structures at risk that you need to be aware of: the superior gluteal and artery and nerve coming out of the sciatic notch, intimately applied across the lateral portion of the ilium. S2AI screws in the systematic reviews that have been done are better than conventional iliac screws, in a large part due to the lower prominence, but other factors as well. And biomechanically, we see that the performance of these screws, the high stress points or the high von Mises stress occur at the offset connector, at the tulip neck junction, and in the S2AI screws where they cross the SI joint. And another study showing that heat map very nicely as it crosses the SI joint. How about current pelvic fixation failure rate? So this work by the ISSG, probably the best adult deformity data set that we have in the world today, demonstrates about a 24% failure rate. And this is a group of very good surgeons. So this says none of us are perfect, and even very good surgeons have what we would consider an unacceptably high failure rate. So in our center, I had an acute failure, and I said, "What's going on here?" Screw popped loose, and the patient fell forward, lost their correction. Asked my partners, "Any of you seen this?" And the answer was, "Yeah, I got one. Yeah, I got one." And so we looked at an 18-month period, 125 patients, and we had 6 failures, so a 5% failure rate. And I was like, okay, what's going on here? And so these are the kinds of failures. They were catastrophic failures. And interestingly, a number of the patients who had transitional anatomy fractured through the transitional anatomy. So we said, do we not know what we're doing here, or is this a problem for everybody else? So we found 13 other centers collected the same data, same time period, so just shy of 800 cases, and we found that persistent 5% failure rate. And you see the univariate and multivariate factors affecting it. So the multivariate factors, the change in the sagittal alignment of greater than 30 degrees was really a big deal. And then whether or not you had solid L5S1 support mattered. So anybody else reporting this? So S.J. Hyun from Korea, nice series, nice radiographic examples of the tulip neck break, the break at the SI joint, and rod dislodgement and set plug disengagement. So all of those are recognized factors. They did finite element modeling, suggested the angulation of the tulip affected this. We've tried to reproduce this in the lab and not been able to confirm it yet, but it's an interesting theory that may explain somewhat of the cyclic loading set plug extrusion failure, maybe. Here's the slide that Jay was talking about. So for me, it's applied anatomy. What lives there and is innervated can hurt. And so you need to make sure you're shooting at the right target, because if you shoot at the wrong target, I'm pretty sure you're not going to hit it. And that there are a couple of biomechanical principles that are important to understand. If we fuse L5S1, we increase the motion at the SI joint by 50%. If we fuse 4-to-1, it's 168%. Conversely, if we fuse the SI joint, the change in the spine is 2 to 4% and maybe 5% added stress on the hip. The physical exam is absolutely crucial. These are the key physical exam maneuvers, and they have high sensitivity and specificity. In fact, it's so good that it constitutes what's called a clinical diagnostic rule, and it's as good as anything that we do in the spine for confirming what's going on. What's the rate of new SI pain after spine fusion? Systematic review by Marco Menzetti says it's 24%. And then how about what if we fuse the SI joint at the same time we fix the pelvis? So we've just completed the data collection on the Sylvia trial, and the publication data that's available currently is that 16% of these patients preoperatively had SI pain. And I'm not sure that that's ever been reported before. And we hope to report this fall on the details about it, and that we're encouraged by the results and are completing the analysis and having it reviewed by a journal. So how about some case examples? So this is a patient, school bus driver in Wisconsin, scoliosis. I fixed her. She was hypokyphotic, in fact, lordotic in the thoracic spine. Today, I would have liked to have gotten more kyphosis back, and did well. And then 2.5 years presented with broken instrumentation at the pelvis. And so what I learned from her and from other patients of mine is S2AI screws, when they fail differently than iliac screws. They halo in the sacrum, and you can see that on the CT scan here. And so my revision strategy for her was 4 rods and then concomitant SI joint fusion. So We've now gone on to develop a screw fusion device. This isn't just a screw, it's a screw fusion device, and it's different than a pedicle screw, and that we'll talk about the design and the data behind it. So the design is different because it is a fusion screw as opposed to just a standard screw. So it's got a significant surface area available for bone ingrowth. And when we put these in, typically we have about 40 millimeters of engagement in the sacrum. And when I use a 90 or 100, about 50 in the ilium. Here's how it's different. It has a center core that is the screw concept, and then it's got this outer ingrowth sleeve that is a bone ingrowth device utilizing that technology. Because it's a big screw, it has a failure mode of R to the fourth, and so it's robust, and we haven't seen any failures of screw breakage to date. We know a lot from interbody devices about ways to get bone to grow onto and into metal. And so this screw fusion device takes advantage of that advanced technology. And does it work? Well, how do we know if something works? Well, in the original uncemented total hip arthroplasties, the way that they got FDA approved was retrieval specimens. Well, we now have a couple of retrieval specimens, late infections, where the demonstration of the robust bone on growth, ingrowth, and through growth has been demonstrated. This is a case example from Vic Patel from University of Colorado, infection 10 months after. He did the revision with the Trefin, took this out, and you see the bony on growth across the screw, and you see the micro CT demonstrating that ingrowth as well. We had a similar case, spondylodiscitis above a revision fusion that I removed the implants, and this is now a published case report. So here was what she was at the start, and here are the removed implants with the micro CTs. And so that case report is available for your review at your leisure. So how about insertional torque? So we know that insertional torque in general correlates with pullout. And so when tapped, quote, line to line, the screw fusion device, the Granite screw fusion device, has better insertional torque than a standard pedicle screw when similarly tapped. How about bone ingrowth? Now, these are the torque screws, and this is a sheep study. So this is published peer-reviewed data comparing it to a standard screw and to an alternative SI fusion device. And what this demonstrates is that there is rapid ingrowth as early as 3 weeks, demonstrating improved removal torque, and that it's markedly improved in 6 weeks. So I think when we have screw loosening, or when we have fusion device loosening in primary SI fusions, it's happening rapidly, probably within the first 3 months, because it's going to heal quickly, and if it doesn't heal, then you have the problem. We've also studied this in sheep with the actual Granite device, and we looked at it at 6 and 12 weeks. Similar pattern, compelling histology, and significant improvement in the removal torque. How about the design parameters? Well, so you saw from the studies where the von Mises stresses were, and so the tulip neck junction is an issue. And this is a material property based on the radius of that implant. And we see that this device has the largest neck on the market, and consequently, material properties say that it's going to have decreased stress compared to those with a smaller neck. How about axial grip test? So this is an ASTM standard test where you put it in a machine and try to pull the rod out of the set plug. And this is based on the final tightening torque of the, in this case, T30 set plug. And so this has the highest torque on the market that we know of, and so should perform better and has the highest axial grip test compared to published data. Interesting question that I don't think has been studied before. How much rod needs to stick out? An important question as we're struggling with these intraoperatively. So we've recently studied this at our place and presented it now at a couple of meetings. And it turns out that if you're flush, it's equivalent to +1 and +10 millimeters. If you're short, however, that results in decreased axial grip test. And I don't think that that's a surprise. It was a pleasant surprise that flush was equivalent to protruding. How much engagement do we actually have in the sacrum? So when we put implants in at our place, we trust but verify, and so we do check spends. So we had a convenient sample of patients where we had Granite screws placed, where we had the ability to look at how much engagement was there in the sacrum, because that's the weak point. We haven't seen loosening in the ilium, and if you're going to get loosening, the place at greatest risk is in the sacrum. So how much sacral engagement do we have? So we were able to measure this, and it's about 32 square centimeters, so a pretty big surface area, giving us a significant opportunity for bony ingrowth. All right, so what about complications? So I previously presented the Martin multi-center data, and so when we compare that to the industry survey about their population data from the complaints database now published, what we see is a log order decrease in the failure mode. If I told you there were no failures, you wouldn't need to listen to anything else I have to say. That what we see is significant iterative improvement. So we're about 10 times better for set plug loosening, for implant loosening, 0 implant break rate to date, and the revision rate is, again, a log order better. It's not 0, but it's a log order better. Okay. And so how much experience exists? So 12,000 cases, 29,000 implants as of March data. What has my migration been? So this is our data from the University of Minnesota. I was never a one screw construct guy, but one of my partners was. And you see that over time, what we've migrated to is more points of pelvic fixation and more rods to the pelvis. Linky and the group at Columbia, similar experience. Pretty darn good surgeon, probably one of the best, if not the best, deformity surgeon in the world right now. And that he had a failure rate with pelvic fixation. And when he went from 2 to 4 points of pelvic fixation, that rate didn't go to 0, but it markedly improved. So how about finite element modeling? So finite element modeling, what's the highest demand that I can think of? So I said, well, how about a L5 PSO? That you've got no real good fixation below it. And so you're looking at maybe you got decent S1 screws, but then you're really asking all of the pelvic fixation construct to hold onto the construct and not have it fail. And so the most rigid construct is a 4-rod, 4-screw construct using the screw fusion devices. And why 2 points of pelvic fixation versus 1? Well, 2 points of pelvic fixation markedly decreases the SI motion. It markedly decreases the stress on the S1 pedicle screws, and pleasantly surprising, it decreases the L5 S1 range of motion. Not sure I fully understand that, but it's a nice adjunct since that's a common site for failure. How about, are we just transferring the load to the adjacent segment being the hips? Well, we looked at our adult deformity population and compared their prevalence. The bottom gray line is sort of a national cohort of what the rate of total joint arthroplasty is. And in our adult deformity patients, we see a 6 to 7 times higher rate of pre-existing total joint arthroplasty. I don't know if it's biology or biomechanics, but our deformity patients, for some reason, their hips and knees are wearing out faster. What if we fuse the SI joint? What does that do to the hip joint? Well, looking at 3 prospective cohort studies, we looked at this and showed that there's about a 2% rate of total hip arthroplasty after SI fusion at 2 years. And in patients who have a total hip pre-existing, there was about a 2% rate of SI fusion. So there is some added stress, not like the stress of spine fusion on the SI joint, but there is some perhaps increased rate. So where am I today? Clinical case example. So no tumors, Jens. Sorry to disappoint you on that. Just a wonderful grandmother with a significant adult deformity, marked scoliotic deformity, getting shorter with age. Here are her bend films. I like the supine CT scouts. They really help us understand the sagittal and coronal plane flexibility. We see the lateral listhesis of L3 on L4, bridging marginal osteophytes as is commonly seen in this scenario. And then I do see some intradiscal opportunities in her. And so I don't know how you define significant stenosis, but I would suggest 4-5 and 3-4, pretty significant. Bone density, treated her with Forteo for 9 months, went through our pre-anesthesia clinic, risk eval complex spine conference. And then we said, okay, go forward with surgery, the debate about how do we do it. I tend to be a posterior only guy, so this is what we did. And then we do patient-specific planning, use patient-specific rods. So here's their patient-specific plan. on the table. How close did we get? We got close. We didn't hit it exactly, but we got pretty close. And then 4 points of pelvic fixation, and then 4 rods to the pelvis. And I used a kickstand on her. Probably didn't need it as much as I thought I was going to need it, but I had it there. So I said, okay, let's go ahead and use it. And here are her upright films. I'm pretty happy with that. And our sagittal profile change, which I think is probably the biggest impact, along with the decompressions. And here she is standing at 1 year, pre-op ODI 47 down to 28. She can improve her walking and standing. And most importantly to her, she can play with her grandkids. Some questions about limb length discrepancy. She needs total hips. Are they more at risk? What about bracing? What about tethering? But here she is, and that's, I think, what we're really looking for, that she's happy with her result. So how about in short constructs? Well, when do we need it? Well, in high demand. So what's high demand? High BMI, high pelvic incidence, poor bone quality, pre-existing SI joint pain. Sacral insufficiency fractures, I think, are increasing in frequency, or we're increasingly recognizing them. High-grade spondy, and then revisions where you didn't get it to heal the first time. So when we fuse one segment, the rate of SI pain, okay. 2 segments, higher. More than that, goes even higher. We have done modeling looking at cost effectiveness in high-risk patients, and at 5 years, we've demonstrated that it would be cost effective to do the concomitant pelvic fixation with SI fusion. And our high-risk patients we defined as high BMI and high PI with a PI of greater than 60. So I don't know, in Seattle, you showed a really skinny patient. I saw one of those once, but oftentimes they are not skinny. And that for us, we've looked at a systematic review of pelvic incidence. Average pelvic incidence is about 50, standard deviation is about 10. So a PI of over 60 is probably a high PI, and they just don't do as well. What about pain after lumbar fusions? Up to 40% of those can be SI. And so if we identify that, then we can address it and potentially resolve the problem. Sacral insufficiency fractures, a brief summary of the literature. I think we're recognizing them more. And here's a patient who came in to see me who had an isolated 1-level fusion. She had a sacral insufficiency fracture, and she was told, oh, it'll just heal and be fine. So we see the almost 40-degree change in pelvic incidence, and she now has a profound sagittal imbalance problem that is a real bear to fix. So can we even fix her, and is it worth it? Because we need almost 40 degrees of change, and that's a big deal. So we looked at this. So you see this example of a patient who had her scoliosis fused and then came to me 2 years after she had her sacral insufficiency fracture. I did not know if I could fix her. So we modeled it, and it suggested that we could. We did this construct, and after 2 years, she was finally able to stand up straight again. So we took this to the lab with a very sophisticated methodology using PowerPoint and modeled the sacral insufficiency fracture, and then modeled PSOs at L3, L4, L5 at various locations, and what does that do? And wherever you do the PSO to correct the sacral insufficiency fracture, you shorten and anteriorly translate the spine. So where am I now? So patient came to me, again, another revision scenario, pre-op planning, intraoperative assessment, and where we got her to with 4 points of screw fusion devices at the pelvis. And again, she is delighted with her result at 1 year out and feels like she got her life back again. And so now I'd like to hand it over to my esteemed colleague, Jay Turner, to talk about S1.
Great. Thanks, Dr. Polly. And thanks, Dr. Chapman, Dr. Sculian, for allowing us to participate. Always a privilege to be part of SSF. So Dr. Polly nicely covered kind of all the challenges around the lumbosacral junction and pelvis, and I want to talk a little bit about specifically the challenges of S1, which Dr. Polly touched on. The next slide. There are many situations where we want to spare pelvic fixation. However, the S1 or the sacrum in general is a poor fixation point with high issues of pelvic failure, up to 42% in some studies. Next slide. A lot of that has to do with the anatomy, the density of the sacrum, the size of the pedicles. So study looking at the shape of the typical hourglass appearance of the pedicles. Next slide. And enormous pedicles, which make it more challenging to capture cortical bone, and lumbar pedicles. You can size the pedicle screw to capture the column of bone cortically, and it's much more challenging with the size of the sacral pedicles. And S1 pedicles can accommodate 9.5 screws almost always. Next slide. And so, when we're thinking about terminating a construct at S1, there are a lot of factors that really increase the risk of failure there. One, there's high biomechanical stresses at L5-S1 junction. One for being the most caudal motion segment of the spine. Second is the angle, that sacral slope. You have a lot of high shear stress at L5-S1, which creates significant mechanical challenge. As a result, S1 loosening rate is very high. And there's patient-specific factors that can make it even higher. One is a high PI. High PI, you have an even higher sacral slope, even greater shear stress and greater stress on the distal screws. High BMI, same thing, greater stress on the distal construct. And the longer your lever arm, the greater the number of levels being fused, the higher stress there will be on those distal screws. And often with these distal failures, they require reoperation for pseudoarthrosis, recurrent radiculopathy, recurrent listhesis, kyphosis. And so it's especially in the degen world, pseudoarthrosis, L5-S1, S1 screw lucency is a particular problem. And it's another nice potential application for granite, instead of just using a standard pedicle screw that's swimming in cancellous bone, where you cross your fingers and hope it holds. The design of granite allows for osseointegration, and so with the trajectories that provide us with the most support with that tricortical purchase at the promontory with medial angulation, we're still doing these the same way, but then you have a 3D architecture that allows for bony ingrowth. So in addition to that immediate fixation, you have a biologic process that increases the chance of that holding and not just being a short-term fixation point that's going to ultimately loosen. Next slide.
Sorry, I'm having a little trouble advancing it. It's stuck.
So I'll just run through a couple quick cases. Next slide.
I'm sorry, I've got to reshare again. It's giving me a challenge.
No problem.
Yeah, it's not letting me share your. Okay, I'm gonna have to stop for a second.
Corey, do you have any? Do you have the backup or?
No, I'm working on it, Ian.
Okay.
So, but you want to take
I
some
can potentially
questions?
share from my side too, if that's
Okay. Yep. If you got it, why don't you go?
here. Let me. If this works better.
Dr. Polly, Dr. Randy Davis really agrees with your tie is spectacular.
Is that showing up?
Yes.
Yeah.
Okay, perfect. All right. So this is a 68-year-old female with adult idiopathic scoliosis that really became increasingly symptomatic. Failed to improve all the standard non-operative strategies. Like many of our older patients had other challenges, like we saw some of the cases earlier presented. Patient had osteoporosis. We got her on a Evenity for about 6 months to improve her bone quality. Now I'm having problems advancing. Okay, there we go. I also like the CT scat to look at flexibility. So this is just looking at the frontal and sagittal planes. Most adult idiopathic, very rigid. Didn't have the vacuum discs that were present in the other case. So we know this is going to be a rigid deformity. And with given that large thoracolumbar curve and the prominent hyperkyphosis in the thoracic spine, we opted for long segments and upper thoracic down to the pelvis with posterior column osteotomies to loosen the spine and help realign. And I have moved toward the 4 points of pelvic fixation with granite and 4 rods. I do like to use the patient-specific rods to kind of, give us a good starting point for, for what we're targeting for our realignments. I have my sagittal parameters that I prefer, and we obviously want to get that spine as straight as we can, but most importantly, keep her coronally, globally balanced, which is a real target there. And so that's what we did. And you can see the construct down at the bottom, with the 4 rods and 4 pelvic screws. And this is kind of where I've settled in my pelvic fixation in terms of the configuration. It's gone through, some iterative changes over time. I don't have the same vast experience as Dr. Polly at my 9th year of practice, but I did start with kind of the 2-screw, 2-rod technique, which I started reinforcing with additional rods to reduce the rod fracture risk. And then, started buying into the concept of multiple point of pelvic fixation to really stabilize that SI joint. I always found it, perplexing that we're fusing all joints in the spine when we're doing these big reconstructive approaches. We're only fixating across the SI joint, and it made much more sense that we'll have, greater stability for these longer constructs with multiple points of fixation at the base. And so initially I'd been doing my accessory bolts and accessory rods laterally, and I found it was creating quite a bit of dead space with those accessory rods running laterally when trying to reapproximate the soft tissue. And as inspired by Dr. Polly, I've moved more toward these medial caudal S2AI screws, which really create a nice compact construct. And prevent all that dead space that you can potentially get with the lateral rod. So this is kind of where I've arrived and where I, this is how my current pelvic constructs are configured for these long segment constructs. And just for, kind of continue the conversation, just for a short deformity construct. This is a 35-year-old male I just recently treated a couple of weeks ago with this known congenital scoliosis from a hemivertebra. He's had, kind of progressive nagging back pain he's learned to live with, but became, we've been following him for a while, and he's became more bothered by, right lower extremity radiculopathy from the concavity of that scoliosis. And so you can see here, this is, one cut looking at that L6 hemivertebra, really, kicking the lumbar spine over to the contralateral side, and it was creating some pyramidal stenosis. And so we talked about different options for dealing with this, and not to just to treat the deformity and realign. The plan here was a left L6 hemivertebrectomy with an L4 to pelvis fixation infusion. And for the shorter construct, I find the 4 rods are less necessary. I still like the idea of having 2 points of fixation, and we're really trying to fuse, not just fixate across the SI joint. The preoperative imaging has had some concerns for the iliac vein really being plastered across that hemivertebra. So I opted for an anterior posterior approach, and really the anterior approach, primary goal was just to free up that iliac vein, so I didn't get into any trouble from the posterior approach. And while we were there, put in an ALIF for some inner body support there, and then did the rest from behind. And here you can see we have the granite screws stacked with 2 rods. I hit a very atretic L5 pedicle there, so we just skipped that there, and it was well realigned, and very happy postoperatively and doing well. There's the pre to post whole body X-rays. That's all I had. Happy to open it up for discussion.
So no, this was like a landmark presentation from both of you, and the soundness of biomechanical analysis and all that is really dramatic. So the age-old question has been always, when we do lumbopelvic fixation, I think we all agree this has been the foundation for our spinal deformity surgery, and you've outlined the population at risk. Let me just come back to the subject of do we fuse and do we think we're fusing the SI joint? How relevant is that? I'll start with you, Jay, because I know the opinion of Dr. Pauly, but I want him to analyze that. Are we actually fusing the SI joint, and how important is that to achieve this, quote, fusion in these longer constructs?
Yeah, I mean, it's a really good question. I think the short answer is we got to study it more and figure out exactly what we're accomplishing. I think, for me, conceptually, it makes great sense, and mechanically, it makes great sense. I think the indications from my standpoint are threefold. One is to address any pre-existing SI joint pathology, which often happens in these people. Dr. Pauly talked about hips and all these other joints that get affected. Often people with adult deformity just have whole body arthritic issues, and the SI joint is no exception. And so there are many patients that do present with SI joint pathology at the get-go. So I think that's one indication, is to try to treat pre-existing SI joint pathology. Then the other is to prevent de novo SI joint pathology from doing a fixation either across an SI joint or through a iliac screw, where you're preventing a new problem from occurring. And then the final is, and I think it's probably the most compelling from my standpoint, which is just try to reduce these failures. 23% distal failures, spinal pelvic failures in adult deformity from the ISSG, shows us we need to be doing something different. So having a more robust distal construct with multiple screws, where we're trying to get, trying to accomplish something different, I think is a worthy endeavor. And I think it's a compelling argument, and we're studying it. We're looking at mechanics. We're looking at clinical studies. I think we, have to demonstrate that we're trying to accomplish we are accomplishing what we're trying to accomplish with these techniques.
Hey, Dr. Pauly, so Dr. Robert Benz is one of our Gold Pass members. We thank him and many colleagues like Dr. Kaplan, Shimandli, Tom Riley for their support. Dr. Benz wants to know, how do you, again, actively place bone into the SI joint? How does the SI joint actually fuse with the granite system? We can mention product names here because it's not CME. So is this a formal SI joint fusion? And you showed the ultrastructural picture of this very cool looking composite screw. How do you actually get bone into the SI joint?
Yeah, so the screws are self-harvesting. They harvest about 2 grams of bone when you put them in. And so you've got that spanning bone grafting and device across the joint. And so the retrieval specimens show that the bone can grow into the screws and create that stable fusion. What we've seen in up to 5-year follow-up with primary SI fusions, lateral to medial with the iFuse implant, is that we do see progressive bony bridging around the implant, but that takes a long time. Izzy Lieberman at Texas Back, who I know you know so well, Izzy would formally decorticate the joint and graft it. I would say that that's not been a standard practice currently. If on a revision case where we've got bad, vacuum phenomenon on CT scan, I think that makes some sense. But on a primary like the grandma that I showed, I'm just putting the screws across and knowing that the bone graft is harvested within the implant. And so you have 2 points of spanning, grafting, and fixation.
Dr. Gold has a question.
So this is a question for each of you. It looks like on your post-operative X-series that the quad S2AI screws are very specifically placed where they're parallel, and the entry points seem to be very specific. My question is, do either of you use any kind of navigation assistance for this to get that very narrow corridor?
Yeah, so I navigate pretty much everything. The joke was that I navigate my toothbrush. My dentist says I don't navigate it as well as I should, but that we use O-arm and stealth regularly at our place. Jay?
Yeah, and the same, especially for the pelvic fixation. I all freehand, thoracolumbar screws routinely, but to your point, the amount of real estate there is limited to get these to line up perfectly and to get the rods to connect perfectly. I think mapping out with either navigation or robotics definitely facilitates, getting everything where you want it.
Yeah, I know Jens's trauma experience, that he really understands the teardrop view very, very well. And that the learning for us as we started going to the fixation and fusion concept is that the caudal implant has to be at the bottom of the teardrop in order to give you room to get the second implant in. And when you do that, almost always that second implant start point is just lateral to the first dorsal foramen. And, initially I was worried, well, what about the dorsal root? Well, when we've exposed it with an open exposure, you've probably done a root resection. The dorsal root's gone. And the advantage of that bone right there is that it's very dense and high quality. And so that improves the purchase. So those have been the learnings is the caudal screw has to be just above the sciatic notch. And then the second screw almost always goes in just lateral to the first dorsal foramen.
Dr. Skubin has a question.
Yeah, David and Jay, that was a terrific talk, and it's amazing how you guys have really, and I think David, this goes back to your, I think you showed the evolution of pelvic fixation. It's really fascinating for me as a neurosurgeon because we always kind of viewed the pelvis as this, you can just land any screw in there, and the whole point was to fuse the lumbosacral junction. It's amazing to see how this has evolved. When you've seen on, like 2-3 years post-op, David, do you see, so you obviously, you have not had you said you haven't had any like failures. Have you seen any fractures across the neck or across the SI joint at all in any screws?
Since we've gone to the quad screw, quad rod construct, I have not had a mechanical failure. I've had a partner who's had set plug extrusion relatively acutely and in an obese revision, high sagittal plane correction patient. But with a quad rod, quad screw construct, I have not had mechanical failure.
And then when you, on these CT scans, when you see, when you look, do you look for fusion across the SI joint? Or what's your endpoint?
Yeah, so great question, Rod, and I think it's a little bit of a different paradigm, right? So the first question is, how's the patient doing? And if they're doing fine, we don't really care what the imaging shows. If they're not doing fine, then we want to say, okay, do we find a nociceptive source of pain? All right, so what can that be? So that could be screw loosening, it could be lack of fusion. But in general, I think the rigidity of the construct with the quad screw, quad rod is such that I haven't seen that as a pain generator. And that I like to use the analogy, if I build a bridge with 2x4s, it'll handle 60% of the load. If I build a bridge with 4x4s, it's going to handle 99.8% of the load. What bridge do you want to go across? And so I think this construct is sufficiently rigid that it's below fatigue threshold for both loosening, and especially with the screw fusion device, and below the threshold for cyclic failure for the rods. And so it's just been really robust. And the bigger question is going to then be, what's that do to adjacent segments? But that's also why you'll see that my constructs, I don't take the quad rods the entire length of the construct, and I try to stagger them so that we have stiffness transition in the upper portion of the construct.
Yeah, Rod, I think your question is really important for, particularly for research, for studying this. When we look at our outcomes, like how do you define if it's fusing or not? We're starting to look at our 2-year outcomes from our grant, and what we're seeing so far, my experience is it's an evolution similar to you see with lumbar and cervical fusion, where you start to see some bridging in a couple spots, and then you get a more robust fusion over time, which takes much longer. But I think it's an important question to define. How are we defining what an SI joint fusion is and where, to really understand how we're doing. But yeah, the clinical outcomes are clearly the most important, but for defining fusion itself, I think it's an important point.
And then how about you guys, for like guys like Woody, who's doing these revisions, have you used those for those, big pelvic trauma or?
Yeah, so let me comment on that. So Woody was one of my residents, and we share a lot of patients that have had difficult diagnosis or difficult salvage strategies. And my challenge is that the challenge with Woody's big washer laterally is if you ever have to revise that, that's a nightmare. Because if you've got ingrowth, you then have to basically chisel that monster washer out. And so I am not a fan of washers because the revision strategy in a fusion scenario can be very, very difficult. And so that's where Woody and I have divergent opinion. He's had good clinical success in general in his patients, so I'm not bad mouthing him. I'm saying that we have a different philosophy, and that my philosophy is anytime you put something in the human body, you better be prepared to take it out, because there will be scenarios where you're going to have to do that. And so I'm thinking not just about the initial strategy, but what about the salvage strategy? And so that's where Woody and I have diverged primarily. And I have no problem with it. My original salvage strategy for failed SI fusions, I worked with Mark Swinkowski, who Jens knows very well, Harborview, prior chair of ortho, and that we would take out the implants. I would place navigated iliosacral screws. He would go in and do an anterior ilioinguinal approach, open bone grafting with iliac bone graft, and that these patients would take at least 6 months to recover, and that it was a big hit and a big operation. Did we have some that got better? Yes. We actually published our revision results, and that I would say they were disappointing. And that now coming in laterally with the more muscle-sparing approach, using that three-sided triangle chisel to take it out, and then placing a larger screw implant, I've had much better success in terms of patient outcomes than I have with the big open anterior salvage strategy. So I think Woody's got an approach. Great. Okay. My concept is, what is your plan B if plan A doesn't work? And that if we have an 85% success rate, it means we have a 15% failure rate, and some of those patients are going to need revision. How do you revise them, minimizing the collateral damage?
Have they been, David, have they been using it for, pelvic trauma and stuff, obviously without the tulip, just putting it in?
Yeah, so there is an implant called Torque, which is a bone ingrowth screw that is being used, and there's now one called TNT that's designed to be a through and through across the ilium, across the sacrum, across the contralateral ilium. And so that has where that's really gotten probably its greatest traction to date is in sacral insufficiency fractures. And again, I just want to say, if you see a sacral insufficiency fracture, please fix it before it deforms, because once it deforms, we don't have a good answer.
Yeah.
This was the fastest 90-minute session ever. We're a little bit over time. True highlight, Drs. Turner and Pauly, and clearly Dr. Pauly wins the best dressed prize by a far shot. Jay,
I'll work on that.
You need to get.
You need to come back here and pick up your next time and wear it. But both of you are, I feel this is like a total treat for our knowledge, and putting that wisdom and experience together in this beautiful array of talks and visions and thoughts is really so cool to see. I'm still just flooring. Dr. Pauly, Dr. Turner, Dr. Screen, and I all agree your retirement has been annulled, and it's not valid anymore. We at the very least expect you to stay on the teaching circuit, because this fund of knowledge needs to continue to be disseminated. So thank you both.
Yeah.
Thank you.
Great talks, you guys. Awesome.